So patient of CA pancreas, diagnosed patient of CA pancreas, referred to a pain clinic to manage severe upper abdominal pain, which is referred posteriorly to the mid back. Pain was initially managed nicely with paracetamol and opioid, but recently pain has increased so much that the analgesics are not adequate to maintain the pain. Patient is a female patient of around 40 years of age and having normal body weight of approximately 60 kg and have no other comorbidities except for patient is diabetic. So, first question is like all other questions for the history is, what is the diagnosis? So diagnosis will be here is the cancer pain because of the CA pancreas. So next question is, what are the differential diagnosis? Means why this patient of a CA pancreas can have pain other than cancer itself. So one of them is myofascial, particularly the back pain, mid back pain can be because of the referred pain or can be because of the myofascial pain also. Then might be having the metastasis, so that might also cause the pain, which is related to the cancer. Next question is, what are the investigations to be done? And for a diagnosis of the CA pancreas, there already must have some diagnosis already done, like maybe CT scan, ultrasonography or MRI of the abdomen has already been done. And say for example, this patient is having a locally invasive tumor without any distal metastasis. Say for example, this is one of the typical picture which patients are being referred to a pain clinic. So already imaging has already done. So what else investigation should you do? Because here you have to remember, this patient has referred to a pain clinic for pain management. So we have to think, and already analgesics therapy are not adequate to give the pain relief. So here the investigation should be related with our interventions. If you wish to do some interventions in this patient, what are the investigations to be done? So what are the investigations to be done? One is routine blood particularly to rule out the infections. Coagulation profile is very, very important because most of the time celiac plexus block is done through puncturing the aorta, or even if you are not puncturing the aorta, because the celiac plexus is situated around the blood vessels, so there is every chance that you are puncturing the vessels. There is no harm in puncturing the vessel unless the coagulation profile is normal. So coagulation profile must be normal. Full coagulation profile, including your PTINR. Then what else? Blood sugar. Because these patients, because of the pancreas is being destroyed, very commonly see a pancreas patients presents with the uncontrolled diabetes. So uncontrolled diabetes is a contraindication, but controlled diabetes is not a contraindication. So patient's diabetes must be well controlled, and we have to look for the blood sugar and the HbA1c levels. Then anything else? Another test, at least some information should be there, and that can be done by yourself to look for the aorta. Because if you are doing the interventions, many times, or the preferred approach is transaortic. So just hold your probe over the aorta and see whether there is any aortic aneurysms are there or it is normal. Aortic aneurysm is one of the contraindication. Okay? So that is another investigation you should do. Just put a probe and see that the aorta is looking normal. Or if you don't have any such facilities, you can have some Doppler studies. to see that the aorta is normal. So these are the investigations to be done. How to prepare this patient? So again, preparation on the day of the procedure and preparation beforehand. So preparation beforehand are all these investigations to be done. And another very important things I forgot to mention on the other day, that in the preparation you should be mentioning another very important things, and don't forget it. That is your proper counseling of the patient. So you have to explain about the patient procedure, and you have to explain about the advantages, disadvantages, complications of the procedure. This is mandatory. Every patient must be counseled that this is the procedure you are going to do, what are the likely benefits out of these procedures, what are the risks involved out of these procedures. This is mandatory to explain to every patient for every interventions. So when this question will be asked, that how you are going to prepare your patient, one of the very important things to be told to your examiner, that I'll be doing the counseling, I'll be explaining about the benefits and risks involved in this procedure. Mandatory. And in your practice also, you should be always doing that. That okay, this is the procedure I am going to do, these are the benefits you are likely to get, and these are the risks involved. And sometimes the risk might be very serious, but you have to tell that these serious risks are extremely there. Yesterday I was discussing about the vertebroplasty. So one of the risks is your death. So if you are talking about the death, so at the same time you have to tell that how rare is it. So I always tell like that. Sometimes I give the example that suppose you are sitting here and suddenly earthquake starts and you are going to die. So that can happen, many times that can happen in any of this. So is it that common? So should I sit inside the building, or should I sit in some ground so that the building will not be falling on my head? So it's like that sometimes the risks are there, but those risks are extremely rare. So but still you have to tell about all the risks, and if you are having the statistics ready, you can tell that okay, the chances of this risk is this much. You can give that statistics also. But you have to tell that this is the risk involved. Say for example, if you are dealing with the vertebroplasty, you have to tell the risk of the death, and you have to tell it what is the risk, what is the incidence of the death. It is extremely rare. Anyway, so this, don't forget to mention about this pre-procedural preparation. One of them is proper counseling and explaining the risk versus benefit. Then how you are going to do the procedure. On the day of the procedure, patient will be nil per mouth for 4 to 6 hours. Proper bowel preparation is important if you are thinking of doing the procedure under the ultrasonography. So you should be giving some purgatives for the bowel clearance. You should be telling nothing to eat in the morning except for the clear fluid. And if the stools are loaded in the transverse colon, you can't see anything there. So that is very important if you are planning. What we do in our center, that we first scan with the ultrasound before taking the OT, see whether the patient, two important things are there, how to decide which way you will be doing. One is, if the patient cannot lie prone, then you cannot do it under the CM guided. CM guided, patient must be lying prone. Ultrasonography line, patient must be lying supine. So normally most of the patients are comfortable in lying supine. So the ultrasonography guided procedures are more comfortable for the patient. But problem is, if the patient is having the huge ascites and if the patient is having the loaded colon, then you cannot do anything, cannot see anything, you cannot do it. So huge ascites, still you can do the CM guided. How? You will be putting pillows under the chest, you will be putting pillow under the waist, on the upper the thighs, and your abdomen will be made free and you can do it. Because huge ascites, whatever is the ascites size, still you can go posteriorly, because posteriorly when you are approaching, you are going through the muscles, no other areas. Ascites will not be encountered on the way. So if ascites is there, then even if the patient has discomfort in lying prone, even then your approach should be posterior, because it becomes, in huge ascites, it becomes difficult to reach to your target with the anterior approach. So when to go for the anterior approach, when to go for the posterior approach? Anterior approach is if the patient don't have that much of ascites, if the patient is not comfortable on lying prone, if the patient is having the clear abdomens, not loaded with stools, then you can go ahead with the anterior approach. Posterior approach, if the patient is having the huge ascites, if the patient is loaded stools, then you can go ahead with the posterior approach. So first, anterior approach, ultrasound guided approach. So the ultrasound guided approach, you should start with xiphi-sternum. In a patient should be lying prone, and before that all other prerequisites should be done. What are those? A intravenous channel should be secured, vital parameters should be monitored, and antibiotic you may or may not give. So now you are holding the probe in a transverse axis, just below the xiphi-sternum, and you search for what? Vertebral body, aorta, inferior vena cava. So these three structures you should be looking for. So on the vertebral body, at the level of the, normally just below the sternum, it will be T1. So the T1 vertebral body with one pulsating aorta, and on the right hand side they will be having the vena cava. And if you are putting little pressure, then vena cava will be compressed, aorta will not be compressed. So now you gradually go down, and you see some gas of blood is coming anteriorly and getting divided on the either side, and it moves with the respiration. So that is one of the important difficulties, because the gas of blood which is coming anterior to the aorta will be seen only in a very small areas, and it is moving with the respiration. So because it is moving with the respirations, we will not always seeing, sometimes it will be going, sometimes it will be coming, sometimes it will be going and coming, and with the respiration. So you can ask your patient to hold the breath for a certain time, for a small period, and then you can scan, and then you can again ask them to just take the breath. So the gas of blood coming anteriorly and going on the either side, this is called Seagull sign. So it will be going on the either side. So what are the branches of the celiac trunk? So coming anteriorly is the celiac trunk. Branches of the celiac trunk: common hepatic on the right side, splenic on the left side, and another left gastric. But left gastric is a small branch, it is not seen under the ultrasound, difficult to identify the ultrasound. So mostly this Seagull sign is what is important. If you are coming little down, then also there will be anterior gas of blood, that is a mesenteric artery, but that will not be branching on the either side. That branches anteriorly. So that is how to differentiate whether it is a celiac or mesenteric. Celiac, after coming, it will be dividing on the other side. Mesenteric, it will not. So by that way you have to identify. So once you are there, so ask the patient to hold breath for some time. You can go either from the right hand side through the liver or through the stomach. You have to go either through that. There is no other second option. So some prefers liver, because if you are going through the stomach, there is a chance of the infection, because gut is always having some bacteria. So that is the reason why you should be, if your bowel is nicely prepared, there is no harm in going through the stomach. But majority prefers to go through the liver. So we prefer to go through the liver also. And another important advantage of the liver is a homogeneous structure. So this we discuss in the ultrasound classes also, what is called acoustic window. What is an acoustic window? Acoustic window is such a window through which the ultrasound beam, when it will be traveling, it will be making the distal structures clearer. So liver is one of such acoustic window. Blood vessels are also some acoustic window, because when these structures are homogeneous structures, so there will be no much the uniformity of the structures, and you can distal to that structures looks very clear, and liver is a very good acoustic medium through which the distant to the liver the structures looks nice. So you can use liver as an acoustic window, and through the liver you can go there, and your target will be the space between the two wing of the seagull. So after coming it will be dividing both, so there you have to inject. So this is ultrasound guidance procedure. And for the CM guided procedure, patient should be lying prone with abdomens, to keep the abdomen free, put some pillows under the chest, under the waist, make the abdomen free, and then the patient will be lying prone. Then by the classical approach, you have to identify both the 12th rib and a line drawn, a transverse line drawn through the L1 spinous process. And then your needle should be entered just below the 12th rib where this line is cutting, and you will be targeting the middle of the L1 vertebral body. Once you are hitting the L1 vertebral body, make the angle, increase the angle and go in front of it. If you are going through the aorta, then it's fine, then one needle is enough. If you are not going through the aorta, then you have to put two needles from either side. And you have to inject the dye should be longitudinal, dye should be within the vertebral body, and you should be able to see the pulsation of the celiac trunk also. So there are 2-3 approaches of the celiac plexus block. One is anterocural, another is retrocural. What is anterocural? What is retrocural? Anterocural means your needle will be advanced little further to go anterior to the cross of the diaphragm. Normally when you are doing at the level of the L1, we go little more and go anterior to that, and it is called anterocular. But when you are doing at the level of the T12, we normally remains posterior to the crura, and this is known as retrocural approach. Anterocular approach again can be classical anterocural, or it can be transaortic. Once you are going through and through the aorta, then it is called transaortic. Celiac plexus block, apart from these two, can also be done under the CT guidance and can also be done through endoscope. Through the stomach, you can put the endoscope and through there it can go, or operative. When the surgeons are doing the operations, then also they can inject alcohol around the celiac trunk. So there are the other ways to do it. But most commonly done is the CM guided approach is the most commonly done. Maximum papers are there in favor of the classical celiac plexus block. What are the complications? Immediate complication is fall of blood pressure. In fact, that is one of the signs that you have done it adequately, just like epidural or spinal. If you are giving spinal and there is no fall of blood pressure, you should be knowing that you have not done properly. Your spinal anesthesia is not like proper. So same way here. If there is no fall of blood pressure, that means you have not done it properly. So because of the sympathetic block, pulling of the blood vessels around the guts will be there, so that there will fall of blood pressure. And that is one of the reasons why you might preload the patient with 1 liter of the normal saline before doing the procedure. In that situation, fall of blood pressure will be less. Then what else? Diarrhea is another complication. Normally diarrhea is self-limited. Hypotension also self-limited. After some time, there will be compensatory mechanism which will be correcting the blood pressure. Also, it will be correcting the diarrhea. Normally diarrhea is self-limited within 24 hours. But if it is intractable, then you can use some drugs which can reduce the motility of the gut. Normally these patients already suffers from constipation. So normally this diarrhea is not that hazardous except for rare cases, or you might be giving those kind of drugs. Otherwise, diarrhea is not that troublesome. What are the other complications? So these are the two immediate complications. Other complications, your needle might be going inadvertently and injure the nearby structures. So what are the nearby structures? Nearby structures, very important structures, is your hepatobiliary tract. You might be damaging the biliary tract. And most dreadful complication is your alcohol might go into the foramen and you are landing up with a paraplegia. So these are the other complications, though it's very rare complications, because when you are giving the drug, normally we are anterior to the vertebral body and there is a muscle layer in between. So normally that is preventing your drugs to come backward. But still it can happen, it has been noted. The complications are much more with the retrocaudal approach, because the needles in the retrocaudal approach is posterior to the diaphragm, so there is more chances of slippage and leakage of the drug towards the foramen. That is the reason retrocaudal approach is nowadays not preferred. Antecaudal approach is safer. What is the concentration of the alcohol to be given? What are the drugs given? So alcohol or phenol are preferred. Can you do radiofrequency for the celiac plexus?
No.
Why not?
Because it's a big plexus.
It's a big plexus, you cannot cover it. So chemical neurolysis is the choice, and we are having the option either phenol or alcohol. First, phenol. What are the advantages of the phenol?
It's not painful.
Yes, phenol injection is not painful. Phenol itself has its local anesthetic-like effect. Second is, phenol can be mixed with dye. So when you are giving phenol, you can mix with the dye and see where it is spreading. So these are the two important advantages of phenol. Disadvantage of phenol: preparation is difficult because it's not commercially available most of the times. So phenol crystals comes and you have to prepare in a water broth. It is very troublesome. If you are having the good pharmacy in your hospital, then they can prepare it. Normally it is done in aqueous solution. Phenol in aqueous solutions, but it also can be done with the glycerol. Phenol in glycerol. But mostly phenol in water is the most commonly done. What is the concentration needed? So normally around 6%. All these chemical neurolytic agents, the damage or neurolysis depends on the concentration. So the more concentrated drug is needed for the larger diameter fibers, and less concentrated drug is needed for the smaller diameter fibers. So for the phenol, sympathetic block is possible with 5 to 6%. If we are going higher, then your other somatic fibers, above 6% is your somatic fibers, above 8% it will be involving also the motor fibers. That's why more than 8% are not recommended, because the chances of side effects will be increasing. So 6%, 5 to 6% or 6% phenol is mostly preferred. Another disadvantage of phenol is the duration of action is very short. 2 to 3 months, maximum 6 months in certain situations. So this is for phenol. Now alcohol. Alcohol, the concentration again depends on the percentage. So if your target is only sympathetic, then 50% alcohol is enough. If your target is along with the sympathetic, if you wish to block the other somatic fibers, afferent fibers, somatic afferent fibers, then 60 to 70% is enough. And if you wish to do the motor block, then your concentration should increase more than 80%, 80 to 100%. So 50% for sympathetic, 60 to 70% for the all other afferent somatic fibers, afferent, not efferent, not the motor fibers. And for the motor fibers, normally divide into these three groups. One is your sympathetic, one is your somatic afferent sensory fibers, another is your motor fibers. So for the phenol it was 5, 6, 8. 5 to 6, 6 to 8, 8 to 10 for the phenol. For the alcohol, this is 50 to 60, 60 to 70, more than 80. So this is your alcohol. So now how much you will be giving depends on you. If you are more than 80%, chances of motor loss will be there. But again, if you are giving more concentrated drug, some study says the duration of actions and the chances of success increases. And if you are using less concentrated drug, you are safe because you are not going to do any motor loss, but chances of success minimizes. For the alcohol, there is another important factor that before giving alcohol, you must be giving local anesthetic because alcohol is very painful. So that dilutes the alcohol further inside the body. In vivo dilution will be there. So that is the reason why even 50%, majority authors do not prefer 50%. At least 60-70% they use because some dilution will be always there. Because you are giving local anesthetic immediately and after that you are giving the alcohol. What is the duration of action of alcohol? 3 to 4 months, but sometimes it can be extended up to 1 year. But most of the situation it is 3 to 4 months only. But it is longer than your phenol. And another advantage of the alcohol is it is not that hazardous to prepare alcohol. It is easier to prepare alcohol than your phenol. Phenol is very highly hygroscopic. If you are putting inside, if you are measuring alcohol in a weighing machine, by that, phenol, when you will be mixing up with the distilled water, by that time it is already liquid. It is so much hygroscopic. So if you are preparing the phenol, so before bringing it to the atmosphere, you must be making your room very cool, no atmospheric moisture. Then only you should be doing it. But still, I have tried it, but it's very difficult. So that's why the accurate percentage of the phenol is always difficult. Because whoever will be doing it, they have to weigh. So during the weighing itself, it means suppose you are taking 10 gram of phenol. Actually, it is not 10 gram because already it has absorbed moisture. So it might be 8 gram or 9 gram like that. So that makes difficulties in the preparing the phenol. So these are the complications. Post-procedural advice. Post-procedural advice, normally we should be thinking of what are the side effects, complications, long-term complications. So post-procedural advice should be addressing those things. Means here, if the patient is having the diarrhea, if the patient is having the motor loss, difficulty in walking, or having some numbness, so if these things happens, they should report immediately. Okay.